With this, we move on to the next session, and our next speaker is none other but Dr. Rajeev Gupta. Dr. Rajeev Gupta is
Hello.
Chair, Preventive Cardiology and Medicine, Eternal Hospital Cares Research Institute, Mount Sinai, NY affiliate, Jaipur. He is Honorary Professor, Mahatma Gandhi University of Medical Science and Technology, Jaipur. He is President, Indian Society of Hypertension, Board Member, World Heart Federation, Geneva 2019 to 20, pioneer in cardiovascular epidemiology and preventive cardiology, and has several publications in various journals, and the most cited medical author from India. I request Dr. Gupta to, I will play his recorded talk because he is in the Netherlands and he may come for Q&As. So please play the recorded talk.
Good morning, friends from the Netherlands. That's where I am today. I'll thank Dr. Manoria to invite me to this interesting conference on recent advances. The topic given to me is what's new in hypertension management in the year 2025. And what I'm going to talk to you is on multiple issues that has been developed. There are now new strategies for diagnosis and detection, new guidelines. There have been also technological advancements in adherence assessment and interventions. What I'm going to talk today is on medicines, on interventions, on obesity intervention, and of course, the cardiovascular disease risk reduction. We all have multiple choices available for treatment of hypertension in our country. There are first-line choices like diuretics, multiple forms, calcium channel blockers, ACE inhibitors, ARBs, and beta blockers. And we also have a number of supplementary first-line drugs. Then there are second-line choices like inhibitors, alpha blockers, sympatholitics, vasodilators, and new drugs. The European Society of Hypertension has given guideline on optimum management of hypertension using a step care approach. And I believe that these are very good for our country because I think what we need to do is to focus on these particular guidelines so that we can treat our patients well. You begin with monotherapy in only very few, normally as a dual combination therapy, ACE or ARBs plus calcium channel blocker or thiazide like diuretic. If they're not controlled, about 60% are controlled. If not controlled, you can combine all these three drugs, ACE, ARBs, and CCBs and a diuretic, and you will find that almost 90% people are controlled. And beyond that, I think if they are not controlled by this particular medication in the optimum dosages, you call them resistant hypertension, and then you refer the patient upwards. There are a few drugs which have been highlighted by the ESC 2023 guidelines: steroidal MRAs, loop diuretics, alpha blockers, vasodilators, and also RNAs, SGLT2 inhibitors, and non-steroidal MRAs. We all are aware of mineralocorticoids, old drugs, and we have been using spironolactone for a long time, mainly in patients with heart failure. But I think they are also very, very important in terms of management of hypertension. And the guidelines clearly mention that if the GFR is more than 30, that means there is no advanced kidney failure. You can safely use them, prefer spironolactone. And if spironolactone doesn't work or it causes lots of gynecomastia, you can switch over to eplerenone, which is also available freely to us. And this sort of approach has also been recommended by the European Society of Cardiology in last year's hypertension guidelines, again saying that spironolactone is a good choice in treatment-resistant hypertension as a fourth drug. And If it's not tolerated, you can switch on to epinephrine. Now we have new drugs which are non-steroidal uh, mineralocorticoid receptor antagonists, and finerenone is also available to us now. We are using it in diabetic kidney disease, also in heart failure, and now it has been shown to be of use in heart failure with preserved ejection fraction. But this is a slide a comparison of spironolactone with finerenone for hypertension. And there are two trials, Fidelity TRH and the AMBER trial, clearly showing that hypertension lowering is lower with finerenone as compared to spironolactone, but the incidence of hyperkalemia is significantly lower. So they are safe drugs. And what do the guidelines say? ESS 23 guidelines said that these drugs may provide future alternatives to spironolactone in treatment of resistant hypertension. They cause lower hyperkalemia. They're useful in hypertension and diabetic kidney disease, and also useful in heart failure with preserved ejection fraction with hypertension. ESC 24 guidelines do not comment on the use of these drugs in hypertension. We are all aware of RNA-ARB combinations, sacubitril valsartan, which are widely available to us, mainly in treatments of heart failure with reduced ejection fraction and emerging use in heart failure with preserved ejection fraction. They were initially used for hypertension, but after a remarkable benefit in HFrEF, the focus shifted to heart failure management. And a meta-analysis with 10 studies, about 6,000 patients, confirmed that this combination was better as compared to valsartan, olmesartan, or amlodipine alone. It is approved for blood pressure management in China and Japan, but not in the US and Europe. The other drug with which we are familiar is the SGLT2 receptor inhibitors, widely used in heart failure, widely used in diabetes. And now it is class 1 indication also if in hypertension, if you have associated kidney disease, and if you have hypertension with associated heart failure. So clearly, this group of drugs is also an important contribution, important new development in the area of hypertension management, especially if you have these sort of comorbidities. With the success of mineralocorticoid receptor antagonists, the focus on RAS and new pharmacotherapeutic agents have developed, and one of the important ones is aldosterone synthesis. And aldosterone synthesis involves lots of steps from cholesterol onto aldosterone. And this particular compound, baxdrostat, which is a prototype for aldosterone synthase inhibitor, has been developed. And now there are three drugs of this class, baxdrostat, vorinostat, and dexpedrostat, and all three phase 2 trials have been published, New England Journal, JAMA, and Lancet, and they showed benefit. And the meta-analysis of these drugs, all the phase 2 trials, have clearly shown that they reduce blood pressure on top of existing hypertensive therapy by about 6 millimeters. So clearly, there's armamentarium to be used. They could be used, but I think the limitation is that they are still in phase 2 trials. Phase 3 trials are ongoing, and it is recommended by various agencies that you need phase 3 trials with larger cohorts and expanded follow-up. It will be critical to determining their roles in clinical practice, including long-term cardiovascular and renal impacts. Another new mechanism is the, again, focus on RAS, and you are trying to silence angiotensin using antisense oligonucleotides, messenger RNAs, and small interfering RNAs or cRNAs. We all know Sirenase, which is inclisiran, is a protein molecule which we all use in people with hypercholesterolemia. So this drug is also a same class of drugs. A new one, zilebesiran, is being tried, a new small inhibiting RNA inhibiting angiotensin inhibition. And 2 trials have been published. The phase 1 trial was published in the New England Journal 2 years ago and showed a clear benefit if you increase the dose of this drug. And JAMA published the phase 2 trial in about 700 patients And what it found was the zilebesiran single injection reduced 150 milligram by 7.3, 300 by 10, and 600 by 8.9. So again, a significant decrease in blood pressure. Surprisingly, the effect of this drug lasts for 3 to 6 months. So you could have potentially have a drug which can prolong blood pressure, which has a prolonged blood pressure lowering efficacy, similar to inclisiran. Like inclisiran lasts for 3 to 6 months. This drug also has a beneficial effect for 3 to 6 months, but only if phase 2 trials, phase 3 trials will tell us whether to use it or not. Hypertension vaccines have been development has been going on for a long time. All are focused on angiotensin peptides, angiotensin 1 or angiotensin 2, and they are still in development. It may increase following the technologies that we use in development of COVID vaccines. Don't forget hypertension phenotypes, and I think one of the important phenotypes is the obstructive sleep apnea. Almost 60-70% prevalence in resistant hypertension according to the US data, and you can easily diagnose obstructive sleep apnea using polysomnography. And CPAP is a treatment of choice. And if you provide CPAP to these patients, the blood pressure, both diastolic and systolic, decreases, and the change in mean blood pressure at 24 also declines. So clearly, there's a scope for treatment using CPAP in patients with uh, obstructive sleep apnea and resistant hypertension. Interventional therapies, I think all the cardiologists are interested in, and there are multiple forms of renal denervation therapy. They are hypothesized to treat resistant hypertension permanently also. Ablation of nerves along the renal arteries in the adventitial layer. They have been evaluated in resistant hypertension multiple trials. Initial trials showed promise. The sham-controlled Simplicity Hypertension 3 failed, no benefit, but now the technology has evolved. And these are data from the Simplicity Hypertension 3, which was a randomized sham-controlled study in North America. And 6-month follow-up, there was a significant change in the regeneration group, but it was also there in the sham control. So clearly, at the end of 6 months, there was no difference in office or ambulatory blood pressure measurement between the control group and the intervention group. However, following that, the technology has evolved. Instead of uh, the delivery devices that were being used, the generation devices that were being used, the design was changed. It has come to a spiral device now, and there are multiple small studies performed using those particular devices, all showed benefit. On the other hand, even the Simplicity trial, when they followed up the same people for 36 months, it showed significant benefits. So clearly, there was some scope for renal degeneration therapy. Now, presently, how do they stand? Pharmacotherapy, we all know, reduces blood pressure by about 13, 11 to 13 millimeters of mercury using these compounds singly. And similarly, what you see here is that renal degeneration therapy also reduces blood pressure by the same degree. So renal degeneration therapy basically is an advance in terms of resistant hypertension management, that you have multiple drugs on board and then you want to do something, blood pressure is not being controlled, then I think degeneration has definite place in the clinical armamentarium. And now, at least in the European guidelines, both the ESH and the ESC guidelines, degeneration has been given an indication of class 2B, which is, I think, a fair judgment in those studies. We don't yet have data we don't have guidelines from the American counterparts. What do they think of this particular therapy in hypertension management? A new exciting focus is bariatric surgery for hypertension. I think for obese people, it could be a boon. Although the initial trial, the initial trial of bariatric surgery was intensive medical therapy for diabetes, not focused on hypertension, showed that the blood pressure was slightly lower at the 5-year follow-up, 134, about 3 millimeter lower that pressure as compared, almost the same as medical therapy. But then there was a retrospective study on long-term outcomes. Kaiser Group in the US, 9,000 patients with hypertension undergoing gastric bypass or sleeve gastrectomy, and compared with 66,000 non-surgical controls. And what you find is hypertension remission, means cure of hypertension, happened in about uh, 14% in non-surgical group and 60% in the surgical. And the risk ratio was 10. So 10 times more efficacious in surgical group as compared to non-surgical group as far as the hypertension management was concerned. And here is a randomized trial to evaluate efficacy of gastric bypass in hypertension and obesity. Now, these are 12-month data clearly showing that almost 83% of patients were off medication as compared to only 12% which were off medication on medical therapies, clearly showing benefit of bariatric surgery in obese people to go get off medication. And this is the 5-year, the final data of this gateway trial just published last year in the JACC. And you clearly see here is that the relative risk was about 5.9. That means people undergoing gastric bypass had a 5.9 times chances of being off medication as compared to medical therapy. Clearly important new development, but remember it is used only in people who have body mass index. So the mean body mass index in this particular study was 37. So clearly only obese people tend to get benefit from bariatric surgery. Now we have new drugs for cardiovascular benefits, GLP-1 receptor agonists, and weight loss and systolic and absolute blood pressure. And what I did was to collect data from liraglutide, semaglutide injection, semaglutide oral, tirzepatide, and these orforglipron drugs. All of these led to a significant weight loss, 20% tirzepatide, 15% semaglutide oral, 15% semaglutide injections, and all led to blood pressure decrease. More the blood pressure loss, the weight loss, more was the blood pressure decrease. So clearly, GLP-1 receptor agonists also have a role in decreasing blood pressure. And this particular cartoon shows that all these GLP-1 receptor agonists decrease blood pressure as compared to the older drugs, which are not very successful. And finally, we talk of reducing cardiovascular risk in hypertension. What is new? I think we all know how to treat hypertension, but I think we have to move beyond hypertension if we want to reduce cardiovascular risk. Escort lipid lowering arm was one of the first trials to show benefit in terms of if you combine hypertension drugs with atorvastatin here, you see that there was at the end of 3.5 years, there was almost 36% risk reduction in coronary events and total cardiovascular events and procedures. And the meta-analysis of trials showing combination cholesterol-lowering therapy in uncomplicated hypertension. 3 large trials all had Escort lipid lowering arm and the HOPE-3 clearly showing benefit, and the overall benefit in cardiovascular outcomes was about 21%. So 21% reduced cardiovascular events if you combine antihypertensive drugs with statins. And now, of course, we have polypills. So polypills is not only blood pressure lowering, also statins, also aspirin. So three form of actions, and this particular meta-analysis in which I was also a part of the polypill trials, showing that if you combine as compared to the usual care, if you take polypill, and remember 75% of people with on polypill in polypill trial were hypertensive, and there was a 38% lower risk if you are taking polypill. That means multi-pronged cardiovascular risk reduction. And it was not only helpful in myocardial infarction, but also helpful in stroke. And surprisingly, if you have With aspirin, the benefit was much more. Without aspirin, the benefit was not as high as it was in people with aspirin. So clearly, polypill has a role there. So, friends, in conclusion, what we have just discussed today is there are new things which have happened in hypertension management in this year, particular year. We have new medications, especially non-steroidal mineralocorticoid receptor agonists. We can now use RNA ARBs and SGLT2 inhibitors in people with specific indications. New drugs are on the horizon, especially the aldosterone synthase inhibitors, the angiotensinogen small interfering RNAs, and hypertension vaccines some time to come. Interventions are now found a place in guidelines, and the regeneration therapy using new technologies are there. Older technologies like ganglion blockade and skeletal sinus modulation, they are not used at all, except in the research surroundings. And especially the exciting news for people with obesity is that both bariatric surgery and the GLP-1 receptor agonist tend to reduce hypertension in these people. And if you lose significant amount of weight, you can get off blood pressure lowering medication, especially if you are obese. And now we have a cardiovascular risk reduction strategies and polypills and statins stand a choice there. Thank you very much. Thank you for your attention.
Dr. Gupta, hello.
Yeah, good morning.
One,
I'm here.
morning.
Thank you.
One of the
Yes.
issue is, should all patients of hypertension be on statins? Your viewpoint.
Thank you very much, Dr. Gupta, for a comprehensive coverage over the new management of the hypertension. Thank you so much.
So, Dr. Gupta, what is your viewpoint? All patients of hypertension should be on
It's a pleasure to
statins?
be. Yeah. Yeah, Manoria sir.
Should all patients of hypertension be on statins? Your viewpoint.
I think the guidelines, I didn't show that particular slide, but there are guidelines from the ESC and the ESH both. They say all the moderate risk and high risk patients should be on the statin. Now, how to define moderate risk or high risk? They do a scoring system like they do in the like they're in Europe. But I think a simple dictum is if you have hypertension with one more risk factor, any risk factor, smoking or obesity or diabetes, they should be on statins. So I think there is no confusion there.
Secondly, the problems with wider use of renal sympathetic denervation is, firstly, the operator does not know whether it has been adequately done or not. Just like angioplasty cannot see the lumen of the artery, cannot see, he can easily see stent placement. So after denervation, there's no way out to see how much extent of denervation is done. Secondly, as you rightly showed, the Simplicity 3
I
trial
think your
6
voice
month
is breaking. I'm not.
the Simplicity 3 trial was negative at the end of 6 months, but showed improvement after 3 years, very significant improvement in reduction of hypertension compared to the sham control. So is there any clarity after how much time the reduction in blood pressure occurs after synthetic denervation? Do you want me to repeat the question?
I think yeah, denervation is still an evolving technology. We still don't know the very long-term outcomes of denervation. I think the only data that we have is the Simplicity 3 data, which showed a continuous loss of continuous reduction in blood pressure. Now, how long is it going to last? We don't know because I think it also depends on the patient phenotypes, other risk factors. But I think it's an exciting area, and at least people who are doing renal artery denervation therapies are very excited with this technology because within the on the table itself, people want to normalize their blood pressure.
Any other questions? So
What
thank you,
was the
Dr.
vaccine? How does it working in hypertension? Vaccines.
Vaccine.
See, vaccine is still an evolving area of research. It's been going on for last, at least I remember, for 20 years now. And initially they focused on angiotensin peptides. So those peptides, they tried vaccines in animal models and all those things. They didn't work very well. One or two vaccines came up to the phase 2 levels, but at phase 2 level, there were no long-term benefits. So sustenance of the vaccine effect is an important issue, because once you have antibodies against some angiotensin system things, other angiotensin molecules take over. So I think the sustenance of the vaccination effect is a long-term issue, and personally, I think it's very difficult to say. I also call zilebesiran or these small interfering RNA molecules as vaccines, because ultimately we may have molecules which will have effect for 1 year or 2 years or 3 years. I think that will be there's the future, using small RNA molecules instead of the large molecule vaccines that are under development.
So thank you,
Hello.
Dr. Gupta, for a
Hello.
very informative talk.
Just, I want to ask one.
Yes,
Yeah.
yes, go on.
Can I speak?
Yes,
Yeah. Hello,
Yes,
Dr.
sir.
Gupta. You have already told in the new management of the hypertension, you have emphasis given on the lifestyle modification, the utility of the exercise. Especially, I want to ask about the salt intake. The people, means our scientists, advocate that the potassium supplementation lowers the blood pressure. Is it true? Or what you want to advocate about the salt intake, especially
So
sodium chloride?
there have been a very large trial in China where the salt consumption levels are very high on a SAS. And that trial showed that it was designed to be a salt lowering trial, but I believe, and lots of other people believe now, that 25% of sodium chloride was replaced with potassium chloride. And there was a significant benefit in terms of salt lowering. And so I think now we are very clear that potassium supplementation is more important as compared to sodium reduction. And I think there is a policy now in China. In China, there has been a huge, very major study on this salt substitution with potassium and showing benefit. I think that's the way forward. Unfortunately, in India, the sodium substitutes, the potassium substitutes were there in the market about 20 years ago. They've all disappeared. So I think
Yeah.
there's right time to think of rejuvenation of the whole concept.
Yeah.
Sir,
Thank you very much.
in recent guidelines, some endotheliin 1 and 2 inhibitors also advised from the European guidelines for the treatment of hypertension. What's your view?
They are used in very specific situations for hypertension management, not in the day-to-day practice. And they are, now used mostly in pulmonary hypertension as compared to arterial hypertension.